And now, to begin our session for the Ask the Experts, please welcome our presenters, Dr. Dawn Dizon, Dr. Susan Modisette, and Dr. Ronald Alvarez, who is today's moderator. Please welcome.
Well, thank you all for participating in today's session. We're honored to actually be called the experts, it's a real pleasure to join you today. And I'm Ronnie Alvarez from Vanderbilt University Medical Center, and I'm going to serve as your moderator today. I promise that this will not be like the presidential debate that we had the other day, or I will kick off the two other speakers off the internet. And so, but let me let them introduce themselves and where they're from, just so you get to know them better. So, Susan?
Hi, I'm Dr. Susan Modisette. I'm at the University of Virginia, so sporting the orange today.
And I'm Dawn Dizon. I'm at Brown University and the Lifespan Cancer Institute.
So I'm glad to have these two people who are just truly experts in the field, and you can sometimes be very entertaining. So I think you guys are in for a real treat today. And so, we have a couple of hours to talk over a number of different topics on ovarian cancer and address many of your questions. And I think for this first part that we will concentrate maybe on some of the questions regarding genetics and genetic risk and genetic testing. And so I'm going to start out with one of the questions that was submitted. It was one that whoever submitted this said they had a sister that they lost to stage 4 ovarian cancer a few years back. And at that time, she completed a questionnaire on her family history and was told that her chances for getting ovarian cancer was very low, less than 1%. And then, you know, subsequently, I guess this was almost like 7 years ago. And then subsequently in 2019, she was diagnosed with a form of ovarian cancer. Again, was given a genetic test, which came out negative. So she's asking a question about, since she tested negative twice for the genetic testing, why then did I get peritoneal cancer? And maybe I would ask Susan to maybe give us some comments about, you know, when do we start doing genetic testing, and how has the indications for genetic testing actually changed over the past couple of decades?
Thanks for giving me something that I love to talk about. So things have changed really rapidly for anyone that's been following genetics at all. So about in 2006, we started a high-risk hereditary breast and ovarian cancer clinic. And when you look back at the history of genetics in ovarian cancer, it wasn't until the 1990s that we figured out some of the particular genes that were involved in ovarian cancer. And back in the early 1990s, we only knew about the two most common ones, BRCA1 and 2. And you guys probably already know this, but BR stands for breast, CA stands for cancer, BRCA1 first gene we found, BRCA2 the second gene. And so up until really about 2006, those were kind of the main genes that we could test for. And back again, before we knew as much as we did, we thought maybe 5 to 10% of ovarian cancer was hereditary, meaning you inherited something that made you get the cancer. But then as we discovered more genes and better ways to test for these mutations, we now think maybe 24%, that's the highest number I've seen, and I'd be interested to see what Don and Ronnie say about that, but could be genetic, meaning you inherited something that you get it. But even so, that means 76% of women that get ovarian cancer do not have something they inherited, a mutation that made them get the cancer. So that's the hard part. Now, one thing about genetic testing, if you got genetic testing back in 1990, you would only have gotten BRCA1 and 2 and not the complete ones. By 2011, we had full sequencing of BRCA1 and 2, but still, if you got tested really before 2013, you would have only probably had BRCA mutation testing. Then the monopolies were released, and a lot of companies are now doing testing. And now if you get testing, you could be tested for 20 genes, 30 genes, 40 genes, 50 genes, any gene that we know about that might have some implications for ovarian cancer. So it's really changed a lot. And the specific question from this patient is, why did she still get cancer even though she doesn't have one of the genes? Even though we know about 90% of the hereditary causes of ovarian cancer, we don't know all of them. So if you have a strong family history, even if your genetic testing is negative, you still could be at risk. And unfortunately, then we have to treat everybody in the family like they're high risk. So it's hard to not have feedback from the audience in terms of where we're going with these questions.
Right, that makes it a little bit more challenging. So Don, not that you're old enough to remember this, but back when we first had the ability
Bless your heart.
Yeah. You know what that means in the South, right, Don?
I remember all of these, I remember back when I was a fellow, we didn't think people were at genetic risk for developing ovarian cancer. So back in the early days of doing genetic testing, even for patients that were diagnosed with ovarian cancer, we still limited testing to those that had maybe a family history. So tell us a little bit about your thoughts about how that has changed and why that's so important.
Right. I think that's a great point to bring up. And yes, I agree with everything that Dr. Modest had just said. You know, we do always look at the family history as a clue to whether or not there's a mutation that might have been inherited within the families. But we also know far more that the cancer itself is as informative as the family history is. That even for women who are only children or who don't know their family histories because they were adopted, or quite frankly, any woman coming in with ovarian cancer, there is still a chance that there is a mutation that was inherited. And we have an opportunity to not only identify to help with risk within her family, but also now to inform treatment. So, you know, it seems as if we're broadening the eligibility criteria for testing. And quite frankly, one of the things we as specialists in the ovarian cancer field are making sure the message is crystal clear, whoever is speaking, but everyone needs to be diagnosed, or everyone needs to be referred for testing at the point of diagnosis. Everybody with ovarian cancer, doesn't matter which kind of subtype. But what I will also add, if I could, Ronnie, about this particular question, I think it's also important to note that there are multiple types of ovarian cancer. And there was something in her question about she had a form of ovarian cancer, and that made me wonder whether or not it is one of these subtypes that may not confer that risk or may not be tied to specifically mutations in BRCA. You know, we like to think of ovarian cancer in a very specific way, and everyone assumes what we're talking about, but it's really important to know that there are different forms of ovarian cancer, and some of those are the ones we worry about with a family history, and others we do not.
Yeah, I remember a sad story of a patient I took care of in the late 90s with ovarian cancer, and we didn't test her because she didn't have any family history. And lo and behold, about 10 years later, her sister comes and has ovarian cancer, and we test both of them, and they both had a BRCA mutation. So it was a really sad story, and I think it points out to why we need to, now the guidelines that say test any and all ovarian cancer patients are so important. And so maybe Susan, comment that even though, I think this is an important thing just to bring up in this forum is, even though the guidelines are there, how many people are really getting tested, and what are the opportunities for us?
Yeah, we are still gaining on it. I mean, it was, if you look 5 or 10 years ago, it was really only 20-30% of women were being tested. And at that point, the testing was primarily to identify what we call cascade testing. We find a mutation in the family. Anyone that's blood related to her could have a 50% chance of having that same mutation, having, risk of breast cancer, ovarian cancer, pancreatic cancer, melanoma, the things that go along with perhaps a BRCA mutation, or the ones that go along with Lynch syndrome. But we were really just looking at the family because that was what we were trying to prevent cancer. But now there are some treatment changes potentially for women that have these mutations. So it's doubly important, one for the family so we can prevent cancer, and also for the woman so that we can optimize for treatment. One thing I want to spin off what Dawn said a little bit was the types of ovarian cancer. Is this probably everyone in the audience knows, but there are 3 types of cells in the ovary. So we've got our epithelial cells, and we lump these together a lot. You know, you've got your epithelial, ovarian, your fallopian tube, and your primary peritoneal. Those are all the same type of epithelial cells, and there can be subtypes of those. Then you have the germ cells. These are the ones that make eggs, and it's a whole different type of ovarian cancer. Most of those are not hereditary genetic. And then the third group of cells are the stromal cells, which are the ones that make hormones. And again, most of them are not hereditary, although there's some exceptions for both of those groups. So just as a reminder, I think most of the time we're going to be talking about epithelial, but if there are some specific germ cell or stromal cell tumor questions, we certainly can address those as well.
So Don, tell me about, what percentage of people are being tested now for germline mutations?
I forgot the question.
That's all right. If you don't answer it, I'm going to ask the next person. So tell us what
something else good though.
Are being tested, what the opportunity is, and why. Susan mentioned Cascade Testing, and why is that so important?
Well, the ideal, and I think all of us are aiming for this, is that we get 100% testing of everyone who's diagnosed with epithelial ovarian cancer, especially epithelial ovarian cancer. We would love to get to the point where everybody does it. I think, Susan, you might know the figures better, but it's nowhere near that.
No,
and
the best I saw was 60, and that was in a certain subset.
Yeah, and I think that's a real missed opportunity. I mean, we're all about risk reduction, early detection, prevention. This affords all of that. And the fact that we're nowhere near 80%, 90% is something that we need to work on as a community, and with both advocacy groups, but our patients are our biggest messengers. And, Ronnie and Susan, you both mentioned it already, but this whole concept of cascade testing, that's where we are going to realize prevention and risk reduction. Because if by testing we can identify someone at risk for ovarian cancer, we can offer her specifically, preventative measures, and that may include removal of the ovaries even before, the risk of ovarian cancer or, the diagnosis is made. And I think those are really huge opportunities for families.
Yes.
So I'm going to ask you a question. This is a question I think that is relevant, and somebody asked a question about this. But so we can send patients for germline testing, but sometimes patients we do somatic testing to see whether they have a potential for a germline mutation. Susan, can you maybe talk a little bit about that? What's the I think there's a lot of controversies about how to do germline testing or somatic testing first. So
let me back up just a little, just to make sure we're all on the same page with the same definitions, because it does get confusing because people hear genetic testing and jump one way or the other. But every cancer is genetic. It becomes cancer and starts growing because you have mutations in the cell that allow it to bypass the normal systems, okay? So every single cancer is going to have mutations, and those are called somatic mutations. Those are mutations that arise within the cancer. Then you have germline mutations. These are mutations in genes that normally safeguard us against cancer. And if you have mutations in them, that doesn't work and you're more likely to develop a cancer. And those are called germline mutations. And every cell in your body has that mutation if you inherited it, versus the somatic or the tumor mutations are only within the cancer cells themselves. So everyone with ovarian cancer should be getting germline testing, and that will identify the 24% of folks that will have a hereditary germline mutation. Somatic tumor testing, I would call it still a work in progress in terms of what you do, but you look at those mutations within the tumor cell for a couple reasons. One, you could identify a somatic BRCA mutation, because it's the same common pathway to get to places, and those might inform your treatment. Or you could identify other types of mutations, KRAS mutations, P53 mutations, and those may inform what kind of treatments and targeted agents might be available down the line. And I think it depends on which number you look at, but if you add the somatic BRCA type mutations, those are the ones in the tumor, to the germline mutations, you may get up to about 50% of women that have some mutation in BRCA that could inform treatment.
Yeah, I think the most important thing is that we get tested one way or the other to see if you have one of these germline mutations. And I think the issue of cascade testing your family members, is really a great way to potentially reduce the risk of them developing ovarian cancer. And so maybe I'll take this opportunity to sort of pivot into talking a little bit about early detection and prevention. And we have a number of great questions about that. And one is like, what we have heard for a year that we are close to having an ovarian cancer early detection test. So what is the current status and potential delivery timeframe for a reliable, readily available, and reasonably priced, and I assume very sensitive and specific early detection test? So Don, you want to bite that one off?
Yeah, I will certainly give it a shot. I mean, that is the holy grail, I think, of this field. We were all, I mean, there is still work being done trying to see what are the precursor lesions. You know, one of the biggest steps that we took forward, I think, in this whole field is realizing that that serous carcinomas, for example, most of them start out in the fallopian tube, for example. So there's so much still to learn, but to answer the question posed, we're not that close to getting a reliable, you know, reproducible test for early detection. And I think, you know, the problem is, like, you know, and everyone here knows that the ovaries are not the breasts. They are not easily tested with a mammogram. And if you think of how you might want to test the ovarian architecture sonographically, even, those tests are invasive. And, you know, one of the biggest screening tests show that, you know, screening in a population way for ovarian cancer, right? There were a lot of other tests that came along with it, and the pickup rates weren't that great. And at the end of the day, the rates of detection of advanced disease were the same. So it's continuing to work. I'm hoping to see a reliable test for early detection of ovarian cancer in my lifetime.
Yeah.
But, you know, if you're thinking it's going to come out before the COVID-19 vaccine, I don't want anyone to be under the impression we're that far on in our progress.
Yeah. Playing off that a little bit, it has been the holy grail, and I've dedicated 20 years to trying to help work this out. But I think there are a couple things that are also unique about ovarian cancer that makes it very difficult to screen for. Dr. Dizon mentioned that we think a lot start in the fallopian tube, and the difference between this and, for example, breast cancer is that these cells may become abnormal or cancerous when they're microscopic. Then, as microscopic cells, they get out of the tubes into the abdominal cavity as tiny, tiny cells that cannot be seen. They don't secrete enough things to get into the bloodstream so that we could pick things up through a blood test. And so they're microscopic, spread, and then grow, versus breast cancer, which is microscopic, grows, and then spread. So we have a chance with radiographic tests to do it. And if you name a test, we've looked at it for ovarian cancer. Any single blood test you've ever seen, as someone has looked at it to see if it works for screening ovarian cancer. And right now, nothing really outperforms the CA-125 as bad as it is. CA-125 and ultrasound are outstanding for picking up stage 3 disease, but they're not good at picking up stage 1 disease. Other things I've looked at, taking, for example, tampons and putting them into the vagina and then collecting some of the cells that come down and then checking those cells for some of the early mutations that we see in ovarian cancer, like P53 mutations or things like that, show a little bit of promise that maybe you can pick up something earlier. You know, circulating tumor cells, taking a bit of blood out of someone to see if you can find any early cancer cells in there people have looked at that. But as of right now, I am personally unaware of anything that really is on the cusp of prime time. I mean, we're all still trying to do these tiny, not tiny, but pilot cells of trying to find these people just after they've gotten into an early stage cancer, and what was different about them. Was there anything we could have picked up to clue us in that it was coming versus finding it when it's too late? I mean, Rana, do you know anything else on the cusp?
No, I think you guys have made some great points. I think one of the key things to remember is that ovarian cancer is just not one cancer. It's probably 20 to 50 different types of cancers, and so and some of which, as Don alluded to, originate in organs other than the ovary. And so we really have to kind of split out what cancers are we really trying to look for. And I think high-grade serous cancer is probably we know it's the most frequent and probably the most, contributes to the most mortality related to ovarian cancer. And so first understanding that it originates in the fallopian tube has been a new breakthrough for us. And people are doing really innovative research looking for the earliest signatures of what are making those cells in the fallopian tube go from normal to abnormal, and then sort of trying to utilize some of the steps that Susan mentioned as to evaluate whether or not they're potential effective as a screening device. Again, I think that for the population we talked about previously, those patients that have inherited a mutation in the gene that puts them at risk for developing ovarian cancer, there's understanding, evaluating their family history and knowing they're getting genetic testing when indicated, and that's oftentimes because they have a relative that's been affected, is really kind of the most effective prevention strategy we can have for that group of patients. But again, 75% of patients don't have any inherited or haven't inherited a gene that puts them at risk for developing cancer. And we know that we don't know entirely what all the risk factors are, but probably they have to do with a number of different sort of epidemiologic features, like risk factors that may be related to lifestyle, reproductive health, fertility, etc. We know some of those, but we don't have the ability to kind of put all of that together to say just entirely how increased risk of developing ovarian cancer one individual patient may be. We know that if you have one of the BRCA mutations, you're probably at the highest risk for developing ovarian cancer. The general population we know has a risk of less than 1 to 2%. If you have a family history of ovarian cancer, but not one of the BRCA genes or another gene, your risk is probably about 2 to 3%. And I'm trying to unravel how can we put together all of these epidemiologic features, like where do you live? One question came through was that somebody lived probably close to California, where there's been a lot of wildfires and the air quality has been pretty poor, and they've actually saw a little increase in their CA125. So risk factors like environmental exposure issues or lifestyle issues or reproductive health issues that we haven't been able to pull together an algorithm that will tell us precisely what your risk may be and how that may inform prevention and screening. But Susan, as you said, the CA125 has been evaluated pretty thoroughly and not been demonstrated to be very effective as a screening device to reduce the mortality from the disease. Can you go over why that may be the case?
Yeah, so the hard part with the CA125 is that, as a screening test, that it can be abnormal in women that do not have cancer, who have endometriosis, have fibroids, have infections, and also the abnormal level. So when a CA-125 is abnormal, in my lab it's 35, that abnormal level is set on postmenopausal normal CA-125 levels. And so again, in premenopausal women, and those are the ones that we also worry about, especially family, their CA-125 is often abnormal. On the flip side, with a really early stage cancer, it may not produce very much CA-125. And so where you would really want to pick up people early is when they're early stage, less disease, and the CA-125 can be normal in those folks. So it misses early disease. It can be falsely abnormal. And I think Don alluded to this early, when we screen with a CA-125 and an ultrasound, and it's positive, meaning they have an elevated CA-125 or they have something that you see on the ultrasound, the only really way to further evaluate is to take the ovary out. And when you look at screening with these guys, these two tests, you end up, depending on which study you look at, whether it's the PLCO or the University of Kentucky data or any of those, you can operate anywhere between operating on 10 to 30 women that never had cancer, never would have gotten it, but because their screening test was abnormal. And that's a big deal in terms of the ovaries do some good things. I always forget they do good things. I just forget about the cancer. And so you don't want to take ovaries out unnecessarily.
Well, I think we talked about prevention. Let's just say a patient has a BRCA mutation, is found to have a BRCA mutation. Don, can you tell us, maybe review some of the recommendations for managing that patient and some of the ongoing studies that are looking at more conservative surgery than taking out both ovaries?
Yeah, so I mean, the gold standard still is to approach patients with a known mutation in BRCA and offer them removal of the ovaries and the tubes, bilateral salpingo-oophorectomy. And that's still the standard recommendation. Now, when you're talking to someone who may have identified that mutation in her 30s, it becomes a more complicated discussion, obviously, of, family planning issues, but also natural health issues of what are the unintended consequences of an early surgical menopause with a BSO. So, depending on BRCA1 versus BRCA2, depending on the family history and the earliest onset of that ovarian cancer, all of that comes into play when we're trying to figure out what ages should we recommend. So I think the nice maneuvers that have been made in this field is really trying to personalize those recommendations of not if you should have a BSO, but when should you have a BSO. But for people who are not ready to undergo that oophorectomy, there is another option, and certainly one that has really, has been a really interesting concept given what we know about the fallopian tubes, and it's removal of the fallopian tubes themselves, called a salpingectomy, and then sort of reserving the removal of the ovaries for a later time. The unfortunate term for that has been called an opportunistic salpingectomy, which sounds almost as if you're gonna you have some money and you're gonna take this opportunity and you're gonna do something great with it. It's still surgery, but it's, if you're going in for whatever reason, you can also take the tubes at the time. So maybe it's because of a woman who is getting her tubes tied, or maybe it's someone who's going in for a hysterectomy for a non-cancer reason. Instead of leaving the tubes and ovaries in, you take the tubes at that point in time. So again, I think there's, and I'm not, the last time I looked, this is a relatively new-ish concept of salpingectomy, and I think we're still waiting for that natural history data to bear out in terms of safety. But I think there's a lot of really nice and thoughtful surgeons, both gyn-onc and gynecology, who are looking at this question and looking at this population who are at risk and trying to be exceptionally thoughtful of how to counsel each person as an individual.
I think it's really important to remember that even for younger patients with the BRCA mutation, we know that oral contraceptives are highly effective in reducing their risk too, and so that's another consideration for us.
Right.
And,
Absolutely.
I think this concept of opportunistic salpingectomy, it's going to be very interesting to see. Most of us surgeon types, like Susan and I, have really widely adopted this for many patients.
Even people that don't have a BRCA mutation, I think that's where we can really make some impact. We even looked into see if people who are getting appendectomy and cholecystectomies who are done with childbearing could, what would it add to those surgeries? Because taking the tubes out on the 76% of women that we have no idea have risk for getting ovarian cancer would do more than the 20% of women that we know have risk. Both are, we want to reduce it for both of them if we can.
Yeah, I agree. And our Canadian colleagues in British Columbia have started this back a few years ago, and we're really anxiously awaiting some of their population data to see how this opportunistic salpingectomy really affects that group that doesn't have an inherited mutation.
Timing, for us at least, for BRCA1 mutation, we think the risk starts going up around 40, but you have to tailor it to family history. So I try not to take the ovaries out before 40 unless there's something else going on. Although I don't know about you all, I have women that show up at 25 and they maybe have even finished their kids and they want them out that early, and I'm trying to have to talk them off the ledge about, I know you're worried you watched your mother pass away from ovarian cancer, but still we don't want to take ovaries out too early. And so trying to tailor that. And BRCA2, you can probably wait a lot longer, a lot, 45 to 50, and some of the other mutations, PALB and BRIP and things like that, you might be able to even wait for menopause depending on the situation. So I think we are doing a better job of tailoring things to people. When you're a surgeon, you just want to take everything out because it just solves the problem, but it creates unintended consequences. So you do have to be thoughtful about it. And the birth control pills, I think this is the most unheralded thing ever. Yes, they prevent pregnancy, and that's why they are marketed, and they've graded that too, but they reduce ovarian cancer risk in half. And I think that is not a fact that is as well known as I would like it to be.
Mm-hmm.
Well, let's maybe pivot to treatment of newly diagnosed patients. And this question was, someone was just diagnosed with ovarian cancer. What would you say the first few steps should be? And I'll just preface that question with the fact that, I've been practicing for 30 years, and the first probably 15 years or so, or 20 years, was sort of a one-size-fits-all approach to ovarian cancer. We typically always did surgery up front. And so maybe, Don, how has that changed over the past decade?
Well, I think, one of the biggest things is to realize that the surgery is not the important part of that treatment paradigm. It's the success of the surgery that really matters. That if you take everyone to surgery and you're not able to take all of that disease out, we are finding out that women who have some disease that was left behind, that is visible, over 1 or over 2 centimeters or more, typically referred to as a suboptimal cytoreduction, it doesn't appear that the surgery would help at all. So here at Brown, our surgeons have taken that and they've really tailored the guidance for surgery in ovarian cancer. And the first question that we approach as a multidisciplinary group is whether or not a woman can have all the disease removed based on what they're seeing radiologically and on exam. If there is a good chance that we can remove all of that disease, a so-called R0 resection, we will 1000% recommend surgery first. But in folks where there is concern that the disease is a little bit more, and also concern that, the physical health of that person doesn't, raises questions about whether or not surgery is safe, we're actually taking more people to primary chemotherapy before surgery, so-called neoadjuvant chemotherapy. But that's our bar here at Brown. Can I get an R0 resection, optimal cytoreduction, or not?
Yeah, I think that's It's been really interesting to see that paradigm shift over the past decade. Once we had a couple of randomized trials that showed us some intriguing data about outcomes and with these two different approaches. So Susan, we used typically Taxol and carboplatin since 1994, 1996 was when the paper came out. What on an every 3-week basis for most people. Tell us about, tell us the journey that we've been on with chemotherapy, particularly there was a question about IP chemotherapy.
Okay. Oh, gosh.
Oh, I can't wait for this question. Go ahead.
All right.
Yeah.
I would love to hear this.
and maybe some of the other the things that have
we tried.
with the chemotherapy regimens we use.
Right. So, and the sad thing is I lived through all of this transition, so it's really easy to remember now. But when we started off, it was actually a platinum agent and Cytoxan was the only two drugs we had when I was starting in the field. And then it moved to, we got paclitaxel or the taxane agents. And so for years and years, it was those two drugs. And then the question came, like, if you had a third drug in, another different type of chemotherapy drug, for example, Doxil or gemcitabine or topotecan, those other agents that we found were effective, not as effective as platinum and taxanes. If you add a third drug to those two, does it help? We found out, no, it just makes it worse in terms of how many side effects with the three drugs. Then, throughout all of this course, we're also asking if we give it a different way, okay? If we give the Taxol weekly, or if we give the drugs intraperitoneally, because most of the disease spreads on that, does that work better? And the hard part is always when you change the drug delivery, is it the actual mechanism of the drug going, the way it's going in, or is it a dose response, meaning you're just getting more dose of those same drugs in if you give it intraperitoneally or weekly? And so, we went through a stage where, our best survival data came with intraperitoneal therapy in terms of big improvement. And so there was a shift to intraperitoneal treatment, although that was really harder on our patients and people didn't like it and you had to have ports. And so I would say there were groups of folks that were really convinced intraperitoneal was the way to go, and then groups of folks that were just waiting for something else to come along so we didn't have to do intraperitoneal therapy. Then adding third drugs came into the targeted agents, the monoclonal antibodies against VEGF, the Avastins, and now the PARP inhibitor. So it's always, what other drugs can we add to this Taxol, carbo, backbone that will improve how many women get in remission? Because we get, even with just the Taxol carbo and a surgery wrapped in there somewhere, you get 80 to 90% of people into remission. The hard part is it comes back. And that's where we're still trying to make it so that we can get everyone in remission and keep them there. So Don, I know you want to say something about
it. I'm gonna ask Don a question. So Don, there's a question or two here about HIPEC.
Okay.
And maybe can you talk a little bit about that in the context of intraperitoneal chemotherapy if you want to add to any of Susan's comments?
No, I think that is a very accurate and brilliant summary of a field that really, at the end of the day, we are still using carboplatin and paclitaxel after all this time. But, there have been attempts at making it more tolerable, right? So going weekly therapy, either the Italian way of giving weekly carbo, weekly paclitaxel, even the Japanese way of giving carbo every 3 weeks and Taxol every week, look really good in terms of activity and less toxicities. And then that big European study compared the standard to these weekly regimens and showed, yeah, you know what, they're definitely not better in terms of our survival outcomes. And in fact, there was a bit more toxicities with the weekly regimens, which was quite surprising in a large European run randomized trial. Along the way, yeah, like Susan has mentioned, IP has come and gone. I think most of it is because so many people are getting chemotherapy up front, trying to get them to that R0 resection. But in Europe, in Amsterdam, there was this very provocative trial where they took folks who underwent neoadjuvant chemotherapy, became candidates for surgery, underwent surgery, and then were randomly assigned. The assignment was to HIPEC, or heated intraperitoneal chemotherapy, versus no heated intraperitoneal chemotherapy. And at recovery, they got more chemotherapy and completed their, quote, standard treatments. And the upshot is that the use of HIPAC was associated with improvements in survival. Now, since that time, coming into 2020, there have been now 2 experiences reported. One of them came out of Sloan Kettering, where it was not a randomized trial, it was a single institutional experience, and it showed that the use of HIPAC didn't seem to improve outcomes compared to historical controls at a very good comprehensive cancer center. So I do think that, you know, the data is still out regarding HIPAC. I will tell you that here at Brown, we have a surgical oncology program where they've been doing HIPAC for a very long time under surgical oncology for appendiceal cancers, mucinous carcinomas of the colon. And so we asked them to review the data and see what they thought, and they thought we could do this. Tailored surgical cytoreduction alongside a gynecologic oncologist, and then HIPAC. I think in another year or 2, we will be able to report our institutional experience of a very standard approach to the upfront management of ovarian cancer. And we'll see. I can tell you today, I'm not convinced that HIPAC does anything, but I haven't looked at the data either. And then I think, you know, the biggest dilemma, I think the 3 of, and I doubt, or maybe I should say doubt, I wonder if we would all agree about the use of bevacizumab in the upfront setting. It has approvals in Europe and the United States, but I have to say it's one of the most contentious arguments that I think we have as a field when we talk to each other on stage like this or debate each other in our professional societies.
Yeah, you bring up a good issue about the use of anti-angiogenics like Avastin, and I think we've seen that you know, this compound has activity in ovarian cancer, and it seems like it's perhaps the most useful scenario is in patients who have incompletely resected disease or stage 4 disease, patients who probably have their prognosis is not as good as maybe those that have had complete resection of their disease or more early stage disease and can be treated with conventional chemotherapy agents. So I think there's still, like you said, a lot of debate about what's the, you know, what patients should be treated with anti-angiogenics. Are there, you know, unfortunately we don't have really a great biomarker like we have perhaps with the PARP inhibitors to talk about who's best to treat them with, or what patient may actually you know, be harmed by it. There was a question here about a patient with kidney dysfunction, and you know, that's we know Avastin can have significant kidney toxicity, and so people with impaired kidney function to start with may not be the best patients to consider using.
Right. You know, and I think, you know, the struggle I think we are all having is that there's an explosion of data on what we can do in the frontline setting. And unfortunately, all of our trials are showing benefits to PARP inhibitors, whether that be olaparib, niraparib, or, you know, bevacizumab with olaparib. They're done as individual trials. And when we try to collate all of this data together, compare across trials, you know, the answers are not straightforward, and they do lend themselves to interpretation. You know, even the studies with bevacizumab done in Europe versus the United States, the outcomes weren't consistent. We didn't find the same things in our US study and the European study. In fact, the dosing used in Europe was different than the dosing used in the United States. So it really, I have to say, it's where the science and the art of medicine actually combines itself, because the art is to know as a doctor, right? There are some things that the data will not be able to tell me, and being upfront about it, and then marrying that with the data that you know, and then coming to a conclusion of how your patients are going to be treated. And I think this is what we do every day.
Well, you've allowed me to do a great pivot to the PARP inhibitors story and in the upfront treatment of ovarian cancer. And so, Susan, there are a lot of questions about PARP inhibitors and particularly PARP maintenance after primary therapy. about how, how do you decide which PARP to use? If I'm on a PARP inhibitor, does that mean I have to take it forever? What's the time limitation? Again, what about side effects? I'm just trying to go through some additional questions here.
I'll just start off with a few of the ones I remember you saying, and then you guys.
Yeah, there you go. That should get you started. Go ahead.
I'll get started. So for both, let me talk just one sentence about maintenance in general, whether it's PARP inhibitor or Avastin. The hard part about all of this is that, to me, as a doctor and having taken care of women forever, is that it's a little bit of a trade-off. At the end of your upfront treatment, if there's no sign of disease, your exam's normal, your CAT scan's normal, your CA-125 is normal, we have you in remission as best we can tell, you would have a certain period of time where you feel the best you're ever going to feel. No side effects, you're not taking anything and all of that. And so the question is, if you're going to take a maintenance that is going to have some side effects, maybe they're totally manageable, how much of that totally asymptomatic time are you going to give up? And is that worth it in the long term? So to me, if you're going to take a drug for 2 years that really adversely impacts your quality of life, but on average that gains you 3 months, and a lot of the trials just show for particular subsets it's only 3 months improvement to taking a year or two of these drugs if it's not one that really is going to work for you, is that worth it? To me, I'm not sure it is. To someone else, maybe it is. And so these are conversations that have to happen with the patients and their families. Right now, having looked at all of the data very closely multiple times, for PARP inhibitors, and this is my bias, I'll be interested to see what you guys do. I feel very strongly anyone with a BRCA1 or 2 mutation, it's a no-brainer that they should be on PARP inhibitors following the completion of their treatment. They have the longest progression-free survival and perhaps a true survival benefit, meaning we're curing more people. So I think those are easy decision. I think if they have a somatic BRCA mutation, again, I think it's a pretty easy decision to put them on it. Then we get to the parts where I'm not as convinced. It would depend a lot on the patient herself, on what she wants and values and how she tolerates drugs, would be the folks that have no mutation at all and none of the signatures that go along to response with a potential response to a PARP inhibitor, the HRD or the loss of heterozygosity, the things that we can look on the tumor and see. And for those groups, the nothing that says they'll respond to PARP and the HRD group, right now, I have really not been pushing for folks that have no signature to go on PARP inhibitors. That's my bias. Now, if a woman says to me, they're out there, I want it, I'm more than happy to give it to them after having a discussion. It is her body, her choice. I will always support her in that. But to me right now, I wouldn't give it to all comers, every single one. And then I would tailor which PARP I picked based on what their other side effects are. One of the PARPs in particular, I've had some patients get really, really sick before we knew it with low platelets. And so there are patients that I might steer away from that PARP inhibitor to a different PARP inhibitor. I don't know what y'all's experience or recommendations at this point are.
Don, talk about the issues of HRD testing. Because I think that's a really important issue.
Yeah, and this comes up quite a bit when clinicians talk to each other as well. So we know that, the end results from having a mutation in BRCA can be, and Susan, you mentioned this already, you can come to that end result in various ways. And one of them is to have your tumor show evidence of a homologous recombination deficiency. So it can be an HRD tumor rather than a homologous recombination proficient tumor, which means, the DNA damage repair functions seem to be fine. So it is possible, and we have shown you can have homologous recombination deficiency and have an intact BRCA gene. So for those patients, there's only one trial that showed a benefit to a PARP inhibitor because they looked at that strata of patients. The trial with olaparib, for example, was really limited to women with a mutation in BRCA. That is where Susan and I completely agree. If you have that mutation, you should go on olaparib. It was an niraparib trial that took everybody and then was able to subset and showed there were benefits for everyone. Everyone should have a PARP according to the niraparib trial. However, I think Susan's point is the one that I take to my own patients, which is, if you have a BRCA mutation, niraparib makes sense. I still prefer olaparib because the benefit in olaparib versus placebo was so impressive. But if you don't have a mutation in BRCA and you have homologous recombination deficiency, this shows a benefit as well. And that benefit was pretty good still. But if you didn't have homologous recombination deficiency and you didn't have a BRCA mutation, you showed a statistically, and this is important, it was a statistically significant benefit to the use of niraparib. Clinically, it translated to 3 months.
It's always 3 months because that's the time between the two scans.
That is right. That's exactly right. So, you made it to the next scan and then half of those people had progressed. So whether or not one wants to take that chance with niraparib, which although it is not intravenous chemotherapy, has side effects, it's a discussion. But I agree with Susan. It's not something I recommend, but I do recommend it for HRD. That's a difference in strategy here. The other thing I'll say, because Ronnie, you had mentioned the subset of women who get bevacizumab, and I have to say I agree with that as well. So if it's someone I'm really worried about, the risk of progression is exceptionally high because you had stage 4 disease or a suboptimal cytoreduction. I will use bevacizumab. I will offer it. But if you also had a BRCA mutation, that is rarely occurring, right? Where you have advanced disease that didn't really respond or the surgery wasn't successful. BRCA mutation, you gave him chemo and bev. I will not continue bev with olaparib. I will discontinue the bev and use single agent olaparib. And, we do have a study out there that looked at olaparib plus bevacizumab. Remember the control arm on the PALA-1 clinical trial was bevacizumab. So whether or not the combination beats olaparib alone, we don't have any information on that.
Right, that trial didn't have an arm that had a sort of a switch treatment type of strategy. So,
Right.
and I think what's really important too is that the whole, the precision by which we can measure whether a tumor has homologous recombination defects or not it's not entirely 100% precise, right? And so,
Right.
So there are a lot of different ways to measure it, and it's good. It's imprecise, and that may be why we're seeing a tumor that may have been designated as HRP or homologous recombinant proficient actually responds because maybe it has a signature of homologous recombinant deficient that's not measurable. Or there may be some other mechanism of action by which these agents are active.
Right. I think, Ron, I think that's such an important point. Even when I talk to colleagues, I'll say, oh, well, her tumor is HRD or it's HR deficient. No one ever asked me, well, what test did you detect that with? But that's an important point. We have no idea about whether or not it's consistently applied as a biomarker. I do agree with you. I think the platform by which you're detecting it has to matter. We don't have any evidence to say it doesn't matter.
I think there were a bunch of people that asked a question about long-term effects of the PARP inhibitors. We're typically asking patients to take these drugs in the maintenance phase for 2 to 3 years and sometimes longer. Susan, you want to comment about what we know about long-term effects and maybe perhaps what we don't know about long-term effects?
Or I think there are long-term effects of both, which I don't think we touched on, both bevacizumab and PARP inhibitors. And so maybe I'll do bev and Don can do PARP, but the bevacizumab long-term, I've had patients develop kidney issues. We check protein and things like that, but you can develop significant kidney issues. We watch for it, but it's not 100%. I've also had some patients with really bad arthralgias where they really get to the point where they're having trouble getting up from the ground and things like that. So kidneys and kind of joint aches are the things I worry the most about. also risk for clots. And so those are the things that you have to think about. I guess, Don, do you want to talk about PARP?
Sure. Yeah. I mean, for PARP inhibitors, you know, I've seen pretty much, to answer the question, the long-term side effect that I think we're all sort of concerned about is really what it's doing to the bone marrow.
Right.
Sort of this, is it making the bone marrow abnormal in its baseline? Are you developing myelodysplastic syndrome? You know, the studies, we're going to have to follow them. If you're taking it after your first line chemotherapy, we don't have any reports of that. The signal there hasn't been a signal that we're increasing it. However, I think we need to wait, because the SOLO2, where they use olaparib in the relapsed setting, is showing that olaparib exposure was associated with a fairly significant rate of myelodysplastic syndrome compared to placebo. But they also showed, interestingly enough, and I can't remember the exact figures, like 11%, but carboplatin in that same trial was associated with a risk of MDS, which was higher than was historically reported. So I do think there may be that risk, and I think we need to be upfront about that. The problem, right, with MDS and trying to pin it down, no one ever ran the trials to say, we're going to do serial bone marrow biopsies on this study. That's the scientific data you would need to try to get at the number of what is the rate of this happening. The reason that didn't happen is it's highly unethical to put anyone through serial bone marrow biopsies, you know, to try to define that. It's a fairly painful procedure.
Susan, we have just a minute or two. So quick word about immunotherapy and the upfront treatment of ovarian cancer.
You want a quick word?
Don't do it yet.
Don't do it. Yeah, it's
not
really
ready for prime time, right? So we'll leave. I think we've had a really good discussion about the journey from the risk factors of prevention and upfront treatment. And this has been a very well-behaved panel. So I'm going to invite them back to join us in
We
about
don't
an
get
hour.
ordered off the panel.
Yes. And so, I hope that, you know, that answered most of your questions that you guys had submitted on these topics. And we'll come back and we'll start talking a little bit more about what happens in the recurrent setting. We'll talk about survivorship, rare tumors, and some other topics that you've submitted. So everybody have a nice lunch, and I've got another Zoom meeting to go to. So
I'm gonna go round on my patients in the hospital real quick.
See you guys soon.
Bye.
thank you, everybody. We'll see you in an hour and a half, or hour 15 minutes.
Thank you, doctor.
Thank you.
Thank you.
Thank you.